Anshuman, have you checked the ma'am's presentation?
Yes, yes, we have checked, sir. It's running fine. All right, it's 7:30.
Dr.
I think
Kaushik,
we
I
can
think we
start.
can.
Anshuman.
Yeah, yeah.
I think we can start.
All right, good evening, everybody. Welcome. Please mute your microphones. All right. I would like to welcome all of you on behalf of Academic Cell of ASGI Hospitals to the 10th session of Learn from the Masters. We have Dr. Muna Bende ma'am with us here today, and the topic of discussion will be optical coherence tomography biomarkers in posterior segment disorders. Among the panelists, we have Dr. Pradeep Venkatesh, Dr. Wael M El-Haig, Dr. V.R. Sarvanan, and Dr. Jorge Rocha. I am the moderator along with Dr. Tanvi Jain. Coming to the introduction of the speaker, Dr. Muna Bende, she needs no introduction. She has been a mentor to the mentors, and she is a renowned vitreoretinal surgeon currently working as a senior consultant and deputy director at Sri Bhagwan Mahavir Vitreo-retinal Services, Shankar Nethrayala, Chennai. She passed her medical school from Kasturba Medical College, Mangalore, and in 1988, ophthalmology residency from Regional Institute of Ophthalmology, Minto Ophthalmic Hospital, retinal fellowship from Medical Research Foundation, Shankar Nethralaya, Chennai, Tamil Nadu, and she has been a faculty in Medical Research Foundation since 1994. She has more than 100 publications in peer-reviewed journals, major contributions to at least 5 atlases brought out by Shankar Nethralaya, and 11 contributions in textbooks. She is actively involved in teaching and training of ophthalmology postgraduate fellows in medical retina and vitreoretinal surgery, and optometrist uh, working under her. She has got special interest in medical retina and inherited retinal disorders and imaging. Welcome again, ma'am, and thank you so much for joining us. Over to you, Dr. Tanvi, for introduction of the panelists. Dr. Tanvi, you there?
Please unmute.
Am I audible now? Yeah, good evening to all. First of all, I would like to introduce our first panelist, who is Dr. Jorge Carlos. He's a practicing Vitreo-retina specialist, and he's the owner of Eye Retina Institute in Brazil. So he has done his medical schooling from Federal University of Bahia and done his residency from the same university. And he has completed his fellowship from Vision Institute of Horizonte. So he has also done a clinical research fellowship in Donny Eye Hospital, California. And he is also PhD from University of Sao Paulo. So there is a non-ending list of, he has been a chief editor of Brazil Vitreo-retina Society, and he has been also in board of directors of Retina World Congress. He was president of Northeast Ophthalmological Society, and he was also secretary in Brazilian Society of Ophthalmology. So I feel pleasure to introduce our second panelist, Dr. Wael El-Haig. He is a professor of ophthalmology and faculty of medicine in Zagazig University, Egypt. So he did his MBBS from the same university, and he did his doctorate degree of ophthalmology, that is MD, from the same university. He did his diploma in disease and surgery in Vitreo-retina from the School of Medicine of California, San Diego. He was a chairman in a department of the ophthalmology in Zagreb University till November 21. He was a chief in division of Vitreo-retinal Society in the same university. He was also trustee and member of Ophthalmology Promotion Board in Supreme Council of Egypt Universities. I take pleasure to introduce our third panelist, who is Dr. Pradeep Venkatesh. He's currently working as professor in All India Institute of Medical Sciences, Delhi. He completed his MBBS from Bangalore Medical College and MD from AIMS, New Delhi. So he did his retina fellowship and training in RP Center, AIMS. He has a never-ending list of 280 publications. He has published many novel articles, and one of them is vitreous-weak syndrome, endoillumination assisted FNSC in intraocular mass. He has authored more than 5 books and edited more than 2 articles. Has been associated with 16 multicentric international studies. Can you change the slide, Dr. Anshuman? Yeah, thank you. So he has been also associated with 16 multicentric study. I would introduce our fourth panelist, who is Dr. V.R. Sarvanan. He is currently working as chief retina and vitreo as chief in retina and vitreo services in Arvind Eye Hospital, Coimbatore. He has done his MBBS from Madurai Medical College and done DO from Regional Eye Institute, Chennai. He has done he completed his DNB from Arvind Eye Hospital, Coimbatore. He was the first fellow of Vitreo-retina from Arvind Eye Hospital, Coimbatore. After that, he joined as medical officer in the Arvind Eye Hospital, and since then he's working as consultant, and now he's a chief. He cleared his FRCS Glasgow in 2004. He's a lifetime membership of many big ophthalmic society. He has presented various papers and chaired many sessions in Vitreo-retina. He has also visited Wilms Eye Society of John Hopkins. So we welcome you all, and we are looking forward to learn from you all. Over to you, Dr. Muna, ma'am.
Ma'am, you can share your start sharing your screen.
Can you see my screen and hear me?
Yes, ma'am. You're audible. Screen slides are visible.
So the talk given to me was OCT biomarkers and retinal diseases, but it's a very long and complicated topic. So probably I'll just confine myself to a few case examples dealing with relevant retinal conditions. This latest article which came in Retina just shows us just how many biomarkers we have in various retinal conditions, starting from disorders of the vitreoretinal interface, epiretinal membranes, lamellar macular holes, vascular disorders of the retina, uveitic disorders, disorders related to drug toxicity, disorders related to systemic conditions, and certain other syndromes. And many of them are described, not all of them may have relevance. So today's talk is on biomarkers, which are specific signs that we identify on OCT, and they can help us in different ways. They can tell us that a disease has occurred. They may be able to predict progression of a disease. They can sometimes tell us what is the possible choice of treatment and what is the possible outcome. Some of them actually tell us, yeah, this is that particular condition, helps us identify a disease. It can give clues to systemic diseases, both vascular and neurologic, and could be indicators of drug toxicity. So we'll just briefly go through some examples. So the first is a predictor of occurrence. Probably the commonest is what you would see in the fellow eye of a patient with this large disciform scar. You see the onion peel appearance, the fibrovascular. You see a combination of type 1 and type 2 CNBM with cystic spaces, subretinal fluid, and we know this eye has a poor prognosis. It has all the clinical features of poor prognosis. However, what is more important is imaging of the fellow eye, where you see pigmentary changes. You see 2 or 3 small specks of hemorrhage. You do an OCT, you scan the entire area, and here you see there is a small pigment epithelial detachment. There is collapse of the outer nuclear layer, and this is an OCT-A-B scan which shows a flow signal. There is also a fluid around the eye, around this area, indicating that this is a small neovascular lesion. So the OCT done carefully will also tell us that there is a neovascular membrane and an apparently quiet-looking asymptomatic fellow eye. So this collapse of the outer nuclear layer with the flow signal within the pigment epithelial detachment and surrounding fluid is an indicator of an active lesion. Now, I'm sure all of us keep hearing this in all presentations that fluid is important, detection of fluid is important. Now, what is the kind of fluid we see and what is its importance? Intraretinal fluid is probably the single biomarker that is indicative of both response to treatment as well as poor visual acuity. And this fluid can be in the presence of cysts, it can be in the presence of edema, as you see here. It can present as macular edema, cystoid macular edema, edema in the retina, can show as exudates, and sometimes both hemorrhage, which could be intraretinal or subretinal. The fluid can be between the neurosensory retina and the retinal pigment epithelium. Again, the presence of fluid has various connotations, and enough of studies have shown us that the presence of subretinal fluid in small quantities could be indicative of a good visual prognosis. I'm sorry, there's some marks coming on my screen. I'm not sure from where. The fluid could be serous or it could be hemorrhagic. The third type of fluid we see is subretinal pigment epithelial fluid. In isolation, there's always a question of do you treat it or not. It's the most difficult to get rid of. And this could be either a serous or a hemorrhagic pigment epithelial detachment, or a combination of both. And the importance of fluid in patients with neovascular AMD cannot be overemphasized, because its presence has a negative impact on best-corrected visual acuity, and reappearance has a worse association with visual outcomes. Whereas subretinal fluid, some people believe it is good for the eye, but most of us would like to get rid of subretinal fluid as well. And sub-RP fluid, as I mentioned earlier, is very difficult to get rid of. The third feature that is important is something that we often mistake for fluid and sometimes attempt to treat it, not realizing that it doesn't work. And this is outer retinal tubulations. You see these circular areas at the margin of the lesion. Basically, these are photoreceptors surrounding an area of degeneration. They are an indicator of poor prognosis, indicates a long-standing problem. In the presence of neovascular AMD, it's a poor prognostic sign. But a good point is, if you see it at the border of an area of geographic atrophy, it is believed to limit the spread of geographic atrophy. So it's bad when there's neovascular AMD and may be protective when there is atrophic AMD. Now, this is a patient of mine with typical AMD, an elderly lady. There are many biomarkers we see, and all of them influence the outcome. Now, she has been receiving injections on a PRN basis for many years and is maintaining a vision of 6.6 in the right eye and 6.9 in the left eye. Now, you look at this orange arrow here, there is a little bumpy appearance of the retinal pigment epithelial. There is no fluid here. This is 2 months after an injection. And 3 months later, you see this small area of subretinal fluid. She has now learned to recognize the scotoma, but her vision never goes below 6.6 N6 and comes back to 6.6 N6 when she's treated. And this cycle has been repeated over the last 5 to 6 years. Contrast it with the left eye. Now, the left eye also has a membrane under the retinal pigment epithelium. There is no subretinal fluid here. You see a small area of intraretinal fluid above it, and what you also see is that there is a membrane on the surface. And if you look at the unfast image, you see there is an epiretinal membrane as well. So she has numerous biomarkers. She gets better with injections, but the edema always, the fluid always comes back faster in the left eye, and the left eye is always symptomatic. And this is because of the negative biomarker, the vitreomacular adhesion. She has some cysts in the inner retina, intraretinal fluid. So that is why her vision quality is always poor in the left eye, though anatomically she improves in both eyes with each injection. Again, this is before and after the injection. This is before and after the injection. You can very well see the difference in anatomical structure between the right eye and the left eye. Now, it's always important to image both eyes, especially when you're dealing with type 3 neovascularization, because we know 80 to 90% of them will develop a fellow eye lesion within the next couple of years. This was an elderly gentleman with advanced glaucoma. You see the scarred membrane in the right eye. You just see pigmentary alterations in the left eye. And then suddenly you see in about 6 months later, you see the scar is exuberantly increased. The left eye looks almost the same, vision is the same, but look carefully, there's a small area of hemorrhage here. And if you were just going to look at the OCT, you would see only intraretinal fluid, and you assume that the patient has developed a vein occlusion. But if you look carefully at the OCTA and you enlarge the size, you see that there is a neovascular membrane here. This is an early sign of a type 3 membrane where you have intraretinal fluid as the presenting feature. Intraretinal fluid as the presenting feature. And just after one injection, you see all the fluid has gone away and has remained like this for the last 6 months. So the importance is catch them early and look carefully, because type 3 lesions are never subfoveal in location. They start in the retina because it's intraretinal, and we know the subfoveal area, there are no retinal blood vessels. So you always have to look in the parafoveal area. Similarly, this is again a fellow eye lesion of a patient with advanced AMD. If you look carefully, there is intraretinal fluid. If you have a disciform scar in one eye and intraretinal fluid in the other eye, always assume this is the starting of a type 3 neovascular membrane, which is exactly what the patient has. And this is confirmed with OCT angiogram. You see this small little membrane, which was not there earlier. And again, the patient does well after an injection. But what is the problem with type 3 lesions? Sometimes they have a tubular structure where you see that the membrane, you see a communication between the pre-RP and the sub-RP space. And you see, though the fluid has reduced, this communication is still there. So you identifying this is important, because this is always a chance for recurrence. So in AMD, OCT biomarkers are not always the same. We've always learned that intraretinal fluid is associated with poor visual acuity and unfavorable visual prognosis, and that the presence of subretinal fluid is linked with better visual acuity and favorable visual prognosis. But when you look at type 3 neovascularization, and I've specifically shown you those images so far, intraretinal fluid always precedes subretinal fluid. So if you see intraretinal fluid in the fellow eye, catch it early and treat it, because those eyes respond better. Subretinal fluid in type 3 indicates a more advanced stage of the disease that does not respond well. And if you have subretinal and sub-RP fluid, indicates a poor outcome. And we all know that type 3 macular neovascularization has a higher incidence of recurrences once the pigment epithelial detachment sets in. So among the various biomarkers, now biomarker is the term for people. Most people use biomarkers as a term, but it's not always imaging biomarkers. There can be different biomarkers, but we see that OCT is important to be able to predict conversion from intermediate to advanced AMD, whether it is dry or neovascular. Coming to diabetic macular edema, this is another common condition most of us see in our clinics, and the patient always asks, one injection, will I do well? Now, there are various OCT biomarkers in diabetic macular edema. OCT is important because it's non-invasive, can be repeated. One of the biomarkers is subretinal fluid. Then you have intraretinal spaces. You can have some hyperreflective dots. Here you see them. You have hyperreflectivity within the cysts. You have distortion of the outer layers, loss of outer layers, and you have these pillar-like spaces between cavities indicating chronicity and shitic changes. So each one of them has a different connotation when it comes to predicting outcomes of treatment. What OCT has also done for us is to detect whether the diabetic macular edema is involving the center or not, or it is non-center involving. And the clue is in the central 1 millimeter diameter, the central subfield zone. If there is no edema in the central subfield zone, it is called non-center involving DME. These are also important biomarkers, the location of the fluid, because you still have the option of observing if the patient has good vision, and you have the option of treating these patients with laser. But if fluid involves the central subfield, then you probably require to give anti-VEGFs or steroids. This is an example of a patient with non-center involving diabetic macular edema. Here you see the fluorescein angiogram, you see the OCT showing this is not involving foveal center. This patient will do well with just focal laser. However, if you have center involving diabetic macular edema like this, even if the vision is 6/9, sometimes you have persistent edema, and then you need to treat the patient with anti-VEGF injections, and you get a good anatomical result. It's not just the presence of edema and the location of edema. If you look at this patient, you see there are a lot of other findings on the OCT. You see there are large cysts at the fovea. There are pillar-like columns adjacent to it. There are very high reflective dots in the areas of hard exudates. You also have some smaller hyperreflective dots. But what is more important is you look at the outer retinal layers, there's a lot of discontinuity. And here you see the layers are thickened. These are all negative biomarkers. And if you look at the central 1 millimeter subfield, you see that the retinal layers are also, inner retinal layers are not well seen. So this patient actually is likely to have a poor visual outcome after even successful anatomical reduction of the fluid. There are certain biomarkers which tell you, yes, maybe the patient should have steroids. And if you look at this patient, there's a lot of intraretinal fluid, and there is also a neurosensory retinal detachment. And you see just 1 month after an injection of steroid, everything comes down to normal. However, we do know that after a couple of months, it will come back again. And most people where there is large amounts of fluid with neurosensory detachment would choose to give steroids. Now you look at this patient who has had panretinal photocoagulation, has had subretinal fluid at the macula and some intraretinal fluid, and you see this hyperreflective structure at the base. Now this patient did not respond at all to 3 injections of anti-VEGF. So then the question was, do we switch? And if we switch, because there's neurosensory detachment, do we switch to a steroid or do we give a stronger anti-VEGF? There's also a little poor prognosis because the disc was pale and the blood vessel here was sclerosed. But it's always important to reassess properly before you decide patient is a non-responder. So what did we do in this patient? We just scanned the entire macula, and you find this was actually a small retinal break. This was a rhegmatogenous retinal detachment involving the fovea. So what you think is a biomarker for steroids was actually neurosensory retinal detachment due to a retinal break. And this patient will require surgical management and not multiple injections. Now coming to biomarkers in diabetic macular edema, probably the best studied biomarkers as predictors of visual acuity in eyes with center involved DME is drill or disorganization of the inner retinal layers. And this has been proved to be a negative biomarker over many studies. In addition, because patients with macular edema, even if they resolve, you see the inner retinal structures are not very well seen. So these patients tend to have poor visual acuity compared to patients where the edema has resolved and all the retinal structures are very well seen. These patients tend to have much better visual acuity. Now, before labeling a patient as diabetic macular edema, it's important to look at the past history. This gentleman had had laser for DME elsewhere. He underwent cataract surgery, and then he came back with cystoid macular edema in both eyes, was advised an injection and came for a second opinion. And when we looked at this, this was so typical of cystoid macular edema, which is pseudophakic. We just gave the patient topical NSAIDs, and you see the result in a month. The left eye is almost resolved to normal. The right eye, the fluid had significantly reduced, and it came down further after another month. So it's important to look at the whole thing before deciding, yes, patient has center involving DME, patient has cysts in the outer nuclear layer. Let me treat with anti-VEGF. They may do well, but they don't really need an injection. Again, when we look at predictors of outcome, sometimes you have patients with subretinal hemorrhage where you're not sure how the outcome will be. This was a patient with subretinal hemorrhage under the fovea following blunt trauma. Before displacing the blood, you look at the OCT. There is subretinal blood. We know that these eyes do well with pneumatic displacement. But if you look carefully, there is a discontinuity here in the brooks and the choroid, and see this alteration in contour. It's very close to the foveal center. So even after displacement, the vision is unlikely to be much better. Here you see the blood has moved away a little bit, and now you see that there is a choroidal rupture running through the fovea. So looking at the OCT, you look at these biomarkers, look at the outer structure, the RP and the Brooks layer, and this will tell you that the patient is not likely to regain very good vision. Now, our biomarkers can also predict progression of disease, and probably what is best studied is the progression of to late age-related macular degeneration. And various structures, various entities, various biomarkers have been looked at. And probably what is most significant is hyperreflective dots, ellipsoid zone abnormalities, drusen volume, and hyperreflective drusen scores. And if you look here, you see this hyperreflectivity here with collapse of the outer layer. And then you see progressively the drusen core is becoming hyporeflective because it's extruding material out of it. And then you start seeing transmission defects indicative of development of retinal atrophy. Similarly, here you see this pigment epithelial detachment, drusenoid, hyperreflective structure on the surface, and gradually converting into outer retinal atrophy. Another finding is outer retinal tubulations. If present at the edge, as I mentioned earlier, it is protective and believed to limit the spread of geographic atrophy. This is one of my own patients. You see over the period of 7 months, you see this drusen here and a little hyperreflectivity above the drusen. Within a period of 7 months, you see that the drusen's core has become hyporeflective. The drusen has collapsed. Now we have some hypertransmission indicative that atrophy is setting in. So these are spots that are important for you to note when you see a patient with drusen, especially if they are drusen close to the fovea. And this is also an interesting study, and we have also seen many of our patients with large drusenoid pigment epithelial detachment. It goes through a cycle where the PED becomes larger and then starts developing hyperreflective dots on the surface. You see the content of the pigment epithelial changing, and then the PED gradually crumples down and becomes atrophic. And if you follow your patients without giving any anti-VEGF treatment, sometimes when mistakes this for neovascularization and treats them, there's usually no response. The natural cause of most of these pigment epithelial detachments is collapse and atrophy. Now coming to OCT biomarkers of disease. There are certain conditions where the OCT tells you what is this likely to be. Now we have hyperreflectivity on the surface. This is a diabetic patient with bilateral problem. Both eyes show this hyperreflective plaque on the surface. You have a widened foveal avascular zone. You have these cavities here. These are irregular hyporeflective spaces which do not look like fluid. And there is outer retinal atrophy. You don't see the ellipsoid zone at all. Here again, you see these areas with almost like a moth-eaten appearance. And then you have the residual internal limiting membrane just draping across this area. You see a same thing on the other side. Now, these features are very typical of MACTEL, or macular telangiectasia. But probably the earliest sign of MACTEL is the presence of these hyperreflective dots in the retinal layers, collapse of the outer nuclear layer here with parafoveal loss. And again, you see these small areas of hyporeflectivity with a few hyperreflective dots. So when you look at this OCT, you can very well suspect that the patient has macular telangiectasia, especially if it's a diabetic with bilateral disease. Now, OCT biomarkers are also helpful as an alternative to more invasive investigations. And we've learned that, especially in polypoidal choroidal vasculopathy, where we were always told that ICG is the gold standard. Yes, definitely ICG has an edge, because if you look at this patient with the serosanguinous pigment epithelial detachment, you see the large network of polyps, but you see only one edge of it is leaking, and there is hyporeflectivity due to a pigment epithelial detachment, indicating that this is active macular PCV. But if you don't have an ICG, you can still see the same structures on your OCT, even without an OCT angiogram. You can have the typical biomarkers of PCV, such as the thumb-like polyps, the double-layered sign, which is not specific, and you have this peaked pigment epithelial detachment and subretinal fluid. Most of the lesion is sub-RP, and these are the typical OCT features of a patient with polypoidal choroidal vasculopathy. And the new consensus nomenclature of the non-ICG criteria from the Asia-Pacific Ocular Imaging Society shows that certain major criteria that you see are very confirmatory of polypoidal. This is the sub-RP ring-like lesion. And if you look at your ANFAS OCT, you see this complex RP elevation. Here you have the pigment epithelial detachment, and here you have the polypoidal complex. So this complex lesion that has two components is also typical of polypoidal choroidal vasculopathy, as well as the sharp peaked PED. Other criteria are clinical, like a complex or multilobular PED, a thick choroid indicating of pachychoroid, and a double-layered sign. We now know that double-layered sign is not specific for PCV. So you can use these biomarkers using an OCT to tell you whether your patient has PCV or just regular AMD. Now, we also use biomarkers to decide how to manage cases, as this patient with thick subretinal hemorrhage. You see, she had a visual loss to 636 N36, a 1 week duration. You see these large dark areas of hemorrhage. We always assume black hemorrhage is sub-RP. It's not always so. I've specifically brought the older OCT machines, indicating you don't always need a swept source or an advanced machine. Here it shows you that there is subretinal as well as a sub-RP component. And we all know that sub-RP component does not do well with pneumatic displacement, but the subretinal component will move away. The ICG shows a small polypoidal lesion here. So this patient, these were the days of photodynamic therapy. So this patient underwent intravitreal gas injection with C3F8 and intravitreal TPA, along with injection of Lucentis. This was when Accentrix was called Lucentis in India, and followed by photodynamic therapy. And you see immediately the vision improved to 6/9 N6 after 3 months. So looking at this biomarker, you could decide that yes, the patient also probably needs tissue plasminogen activator and more aggressive treatment rather than just pneumatic displacement. Another biomarker we now know is part of the pachychoroid spectrum is the presence of focal choroidal excavation. You see this patient with this depression here and at the edge of a polypoidal lesion. This is one of the newer biomarkers for the pachychoroid spectrum, indicating a newer component, that is the presence of the focal choroidal excavation in a patient with pachychoroid. The patient can have neovascularization or polypoidal lesions at the edges. Coming to another condition, inherited retinal dystrophies. OCT definitely has a role as a biomarker. The reason being OCTs can very well see the outer retinal layers, which include the ellipsoid zone and the external limiting membrane. We can also see the RP and choroid and the inner retinal layers. So the outer retinal bands, which are very well imaged, are involved to a different extent in different forms of retinal dystrophies. What is used fairly commonly now is measurement of the spared ellipsoid zone in patients with retinitis pigmentosa, just to measure how much it progresses over time. And you see this patient from 2011, 2013, 2015, you see how little the viable retina has remained. And this is an important biomarker now, because we are going to have more and more clinical trials where you require non-invasive biomarkers to test the effect of your therapy. And probably I would like to share this particular case of mine because this is an important biomarker, the presence of the elongated photoreceptors over an area of subretinal fluid, presence of intraretinal chytic spaces, fluctuating subretinal fluid that does not respond to anti-VEGF therapy, bilateral disease in a young patient, hyperope, sometimes with glaucoma. You have this little fibrotic scar at the fovea. This is very typical of bestrophinopathy. And the reason this particular biomarker is important is many of these patients have had multiple injections of anti-VEGF, switching, moving to steroids, everything without picking up this diagnosis. The other point you would like to do in these patients is take an autofluorescence image, and it will show the typical hyperautofluorescence changes around the arcades in this particular condition. Now, OCTs can also give us clues to systemic disease. This is a diabetic patient who was referred for anti-VEGF therapy for diabetic macular edema. Here you see the patient has bilateral neurosensory detachments, very little intraretinal fluid. Always take a look at the blood reports of the patient when you have a patient with bilateral neurosensory detachment. The patient had an abnormal hemogram. He was diagnosed to have multiple myeloma. So we deferred the treatment. He was treated for his diabetes and the multiple myeloma. 6 months later, you see the neurosensory detachments have disappeared. Then the patient underwent focal laser to extrafoveal microaneurysms. So the presence of bilateral neurosensory detachment always should be a red flag to look at systemic conditions. Multiple myeloma, sometimes more hemorrhages indicate chronic myeloid leukemia, but patients with bilateral neurosensory detachments look for multiple myeloma. Probably an important investigation now one would do is OCT for patients on medications, most importantly, hydroxychloroquine toxicity. And here the biomarker lies in the outer retina. And here you see loss of ellipsoid zone, which can be more and more advanced, and the typical flying saucer sign, where you have a ring-like area of atrophy around the fovea. This is very typical of hydroxychloroquine toxicity. So if you see a patient with a picture like this, always ask them if they've been taking medications for arthritis. And this, of course, is the moth-eaten appearance, the late advanced sign of hydroxychloroquine toxicity, which is definitely irreversible. And if you look at the AO guidelines, they always tell you for the Western world, but in Asian patients, there have been enough studies to show that the pattern of damage may be extramacular. Hence, you need to look in the parafoveal lesion reason for changes of atrophy. And more interestingly, now OCT is now used as an imaging biomarker for neurodegeneration and systemic disorders, both in adults and children. We've seen enough of reports now on it being used in Alzheimer's disease as well as multiple sclerosis. And here we are mostly used to looking at the outer retina as a biomarker. But now when we look at neurological disease, we need to look at the inner retinal layer as well. And these are the certain features that you may see in patients with neurological disorders. But it's always important to know that it's not always the retina. Now, this was a young boy who was seen here with some scars at the macula in the right eye, and he was suspected to have an optic disc granuloma in the left eye, and he was about to be investigated for sarcoid and other pathology. These lesions were unresponsive to systemic steroids, which he had been taken for many months. Was referred to the retina clinic, and we did an OCT. And you do find, yes, there is some subretinal material here, but always image the optic disc as well. Within the optic disc, the elevated edematous optic disc, you see this hyporeflective core. And then you see this ovoid hyporeflective structure at the borders. These hyporeflective cores with the hyperreflective border are very typical of optic disc drusen, which you can pick up very well on your autofluorescence imaging. And this is actually forms, which is what happens when the disc gets enlarged, it pushes the axons to the side. So you have these peripheral hyperreflective ovoid mass lesions. So they correspond to herniating nerve fibers, and they are a marker of axoplasmic stasis, and they can occur here. These are forms. This is optic disc drusen. And these lesions can occur associated with papilledema, associated with disc drusen. They can also be present in patients with central vein occlusion, NAION, and also if the disc exit is abnormal. So this is also something more and more we are imaging the optic disc in retinal conditions to see whether there is some pathology in the optic disc as well. So I've just gone through some conditions where we found OCT is helpful to prognosticate or to decide whether a disease exists or not. This is by no means a complete list, and I look forward to more questions and discussions as part of the panel. Thank you.
Thank you so much, ma'am. I would like to ask a question. In one of your previous slides, where you uh, brought up bestrophinopathies, the
Yeah.
picture exactly looks like what we call a case of chronic CSR, right? Thin
Yeah.
SRF and that gravitational tracts. So, do all such cases of chronic CSR, which we so-called we label as chronic CSR, so should we think about bestrophinopathies in all of such cases?
Actually, more than the chronic subretinal fluid is those elongated photoreceptors, what's called the Verhoef's membrane.
Okay.
This is in a younger patient, but we have seen these patients as they get older, the photoreceptor layer becomes thinned out, and then it becomes a little more difficult to distinguish. But if you do an autofluorescence imaging, a chronic CSCR will have the tracks going down. So you have your hyperautofluorescence going down, whereas here
Yes.
it's very symmetrical around the arcades. So if in doubt, always get your autofluorescence image. You can do an EOG if you have the facility, but many of these patients are not able to fixate well, so they're not able to perform well. But your autofluorescence imaging along with the OCT picture will definitely give you a clue. Because this is a
Probably
very
those cases.
common misdiagnosis. That's why I brought up that particularly.
Yes, it is actually. Chronic CSR, many of our patients we see, even after multiple sittings of focal laser, they don't respond. So probably that is the reason we should go for an autofluorescence in all such cases who are not responding to focal lasers. All right. So let's take the discussion further to our panelists. Dr. Pradeep Venkatesh, presentation and the OCT biomarkers. Dr. Pradeep,
Yeah,
am I
thanks, Anshuman. Thanks. Yeah, and that was a very elegant presentation, Muna. And you shared a galaxy of a gallery of images, and I think there was a lot of learning in the presentation. I mean, I don't get too stuck up with the OCT, frankly, Muna, because I think I'm more comfortable making a clinical diagnosis and then I mean, taking my decisions there. I derive more joy taking decisions based on my clinical diagnosis. And somehow I personally feel that the word biomarker is probably being used imprecisely because, like, you started your presentation saying that not many of them are actually biomarkers. So most of these features essentially would just be diagnostic features. Really do not know why many of them are being really branded as biomarkers. So that's my view, yeah. So I'd request the other panelists to give
Yeah,
their view on this. Yeah.
I agree totally with you that clinical is definitely first, because if you don't know what you're looking for, then you won't find it. So I think you need to take a good history. I'm very much old time in that. Take a
Yeah,
good
right.
history, examine the patient, and then do your OCT.
Yeah.
So then it will tell you what, because typically that case I showed of the neurosensory detachment not responding to injections. And then it
Yes.
turned out to be a rhegmatogenous retinal detachment. That's very common. So
Yeah, because the other way around, just as an example, I'll tell you what happened to me. This was probably in 2004, 2005, early days of OCT. So one of our fellows in the cardiology department, he just walked into the office in the evening with a OCT printout, and then it had a neurosensory detachment. And he wanted me to see him. I told him, "You have already been seen at one of the best centers." It was seen in one other center in the north, and some of the faculty members had seen, and they made a diagnosis of CSR. And so I refused to see him. Okay, and then I met him a year later. There was again a meeting at the very same institute he had been seen, and at dinner time, I happened to meet him, and then I asked him whether he was doing well. And then he told me what had actually happened was he developed symptoms in the other eye, and then they looked for cells, and then he actually had evolved into an Harada's disease. So, from what Dr. Munna is also saying, a clinical evaluation. So even if it's just a simple neurosensory detachment, I mean, they could just come to you in the early stages. And unfortunately for us, most cases we see they already come in very advanced stages. You don't make a diagnostic mistake. Okay, but in the early stages, very few patients who come to you with a simple neurosensory detachment, and then it's actually Harada. So a simple mistake of not seeing the patient on the slit lamp creates a problem. Okay, so I think you should always forget that the OCT is there. Do a thorough clinical evaluation and then take a call on what the OCT is. And there's a joy with clinical diagnosis, and then OCT gives you corroborating features. Then you feel good about your clinical diagnosis. So for youngsters, I would always request them to inculcate the clinical skills and not directly get an OCT done. Yeah, that's yeah, Anshuman.
coming to Dr. Wael? Dr. Wael, please, your comments. Unmute yourself, please.
Yeah, thank you, Dr. Mona, for the very interesting presentation. Regarding the use of OCT, I mean, we don't jump into injections simply because we see fluids. As the previous speaker mentioned, once you see fluid in the macula, you go into the differential diagnosis of causes of macular fluids, which is a long list. And the parallel long list is causes of macular neovascularization. So it has to be covered first before going into injections, because it has been the regular practice, maybe here or anywhere, that fluid means injection. And there must be clear also lines between VEGF-driven fluids and non-VEGF driven fluids, because this is what happens. We don't want to bring it back. You start injecting the patient, then you are not getting results, then you start to re-evaluate your diagnosis and end up that it was the wrong diagnosis, it was the wrong patient. So this is the advice. And from the clinical point of view, regarding those cases of Best disease, usually we see vitelliform lesions, at least in the presence of very good visual acuity. I usually don't see those. I've seen many and many cases of Best vitelliform, typical and atypical forms. Atypical forms is completely different. With the typical forms, we're not sure if it's fluid or not. To start with, it's a space. It's a hyperreflective space. We don't know what it is. We didn't go. There is no. We're not sure if it's fluid. Then the only situation for me personally, after a long experience with seeing Best vitelliform lesions, when they develop macular hemorrhage. At this point, I'm sure that there is neovascular networks, because in many cases with those protruding hyperreflective lesions within those hyperreflective spaces, even with OCT angio, you see pathological flow. We tried many times to inject them, they never go. So the only sure sign then is the development of tiny hemorrhages within the macula. Then for those lesions, I start injecting. Thank you very much. Thank you. I'm done.
Please unmute Dr. Anshuman.
Coming to Dr. V.R. Sarvanan. Dr. Sarvanan, your comments, please.
I think sir is not here.
Okay. Dr. George.
Well, Dona Muna, congratulations. One of the best talk that I haven't seen about OCT biomarkers. Is impressed. We have so many biomarkers that help us every day, not only for the diagnosis, but one point that I'd like to emphasize is the prognostic. If you have like a drill and you have a lot of fluid, we're going to inject in the diabetic patient, but they're going to improve in the sickness, but the patient will not get very good vision or venous occlusion. And then we have to talk previously with the patients very carefully about what is the target and what we should do in this case. And this chronic case that you have seen just shown us, one of big cyst. This big cyst can also have a ischemic in the very deep plexiform vascular, and this can kill the photoreceptor. And then also we can remove this fluid, but the patient will not get very good vision. Also, in the first case that you have shown us about the patient with neovascularization that has hyperreflective material underneath the retina, is the bad prognosis for AMD. We can treat these patients, but we know that's not improve a lot. We can talk for a long time here about all these prognostic factors that is real biomarkers. And it's it's important that people know that we have talk with the patients. This is going to help us to make the relationship with the patients much better, because the patient has a lot of expectation, and when you know how the lesion and the disease will go, and then going to be much better. Thanks so much for your fantastic talk, and we can talk this for a long time because biomarkers is incredible thing, but just my little 2 cents comments.
Thank you, Dr. George. I think we should take up some questions from the comment section. Our audience has put up some questions. Dr. Tanvi, can you please take up the questions in the comment section, please?
Yeah. First of all, thank you so much, Dr. Moona ma'am, for such a thought-provoking presentation. There are few questions. The first question is how to differentiate between ARMD and primary vitreoretinal lymphoma by OCT.
What's the question?
So I'll repeat the question: how to differentiate between ARMD and primary vitreoretinal lymphoma by OCT?
That's
lymphoma and AMD.
Lymphoma, primary intraocular lymphoma. Yeah. Dr. Mona, you go ahead.
Yeah. Now, primary vitreoretinal lymphoma can have various manifestations. And AMD is usually a bilateral problem. You have the typical drusen. Whereas lymphoma, you can have sub-RP deposits, but they can be more irregularly placed. They can be in various locations, not necessarily only at the fovea. You can also have those typical sheets that you get of subretinal lymphoma. You can get lymphomatous deposits in the choroid as well. If you have just one or two drusen, then sometimes it is a little complicated, but I think you need to look at the clinical picture as well before you decide. I didn't bring any examples of that, but maybe I should have. Yeah.
Let me add that in the retinal folds even on clinical examinations.
The very good point is the underneath retina abnormality is not only in the macular area.
I'm a little intrigued by the question itself. So if we could just go back and find out, because we've not faced this dilemma ever. So I'm a little surprised as to why this question came about. So if the person there has had some kind of a patient where he made a mistake, or there was initial consideration of AMD and then it was lymphoma, it'll be good to hear from the person itself on to why this question came about.
Sure, sir. I'll ask the person if they can come. Meanwhile, I'll just go to the next question, sir. So, what to do when we see the drusenoid PED and when we know it is going into atrophy over months? Can something be done about it?
Someone else, so you want me to take a call? Yeah. Not every drusenoid PED lands up into atrophy. There are certain drusenoid PEDs which collapse and the vision remains reasonably good. I have a few patients where they have not landed up with poor vision. Now, which of them, some of them have little rips on the surface of the pigment epithelium. And those are the ones which are more likely to go into atrophy. But the ones where the retinal pigment epithelium remains intact, they somehow tend to have a good vision at the end. You can't do anything about it, but you just have to keep the patient informed, continue with your supplements, but there's no specific treatment as of now. Anti-VEGF injections are not known to work as a rule.
I didn't get the question. What is it with the senile PEDs?
Drusenoid PDs.
What is it? What is
Drusen-
senile
Prevent
PEDs?
them from going
Yes.
into atrophy.
It's we know very well the classification. With age-related PEDs, you have four types. Four types. The fibrovascular, which is called type 1 MNVs. You have the hemorrhagic PEDs and the serous, which we don't treat, and the serous vascularized. And this is treatable. Then you have the drusenoid PEDs that with time can lead to MNV. So senile PEDs is a very wide term that, it's ambiguous. That's why I was asking what kind of PEDs in an old patient. That's what you see.
Doctor, well, it is not naive PD, it is drusenoid PD.
I didn't see drusenoid. Yes, drusenoid PEDs, usually they develop MNVs above it, and you pick it up. The best way you pick it up is with fluorescein angiography. I've seen some good number of these cases because with drusenoid PEDs, usually in the late phase of the angiogram, the dye fades away. While in the presence of CNV developing on top of the drusenoid PED, you get the hyperfluorescence and the diffusion continues with the late phases. So I find fluorescein angio is more important in detecting early macular neovascularization with drusenoid PEDs.
Yeah, thank you, sir.
And you see that if you have the colors before and after, before developing the MNV and when it develops, you see this infiltration, the fibrin, then you can detect it clinically, even with the biomicroscope, that there is a grayish area just above the PED. Then you ask for the fluorescein angio to confirm.
So, can we take few more questions, sir?
I can just make a comment since I think I know I found one case which could probably answer that question that somebody asked about drusen versus primary Vitreo. I think it was that particular sign that they were looking for. I don't know who it was, but allow me to share my screen. I'll just show that slide. Is it okay?
Yes, please.
Yeah, 1 second. Okay. Now, sorry. If you look at the top left, you see there are drusen here and you see this vertical line going up. I think this is what the person concerned was asking about PBRL, because sometimes you have drusen with this vertical line which goes in the intraretinal layers. Now, in this patient, it has converted into an area of atrophy, but in case of PBRL, it will not convert to atrophy on its own. And this picture can move from one location to another. So that is something that people sometimes say causes a difficulty in differentiating between drusen and lymphoma lesion. This is one of the things that I could find this on my screen, so
And I can show you my latest case of the lymphoma, if you'd like to.
Yes, please, sir.
Where's my screen? I'm not able to. No, I'm not. Oh, here we go. This is my screen.
Meanwhile, we can take up another question from the
Oh,
chat box.
yeah, please, yeah.
Yeah. Which injection to be given when we see hard exudates very near to fovea, as when we inject the hard exudates goes to the foveal region from parafoveal and vision deteriorates. Should we go give only steroid, or we should give the combination of anti-VEGF and steroid? Shall I repeat the question?
Maybe Dr. can answer that.
Yeah, Muna, you were.
I said maybe you can take that question.
Okay, yeah. So I mean, if the hard exudates bilateral, I think you need a systemic workup first. And most of these patients with the hard exudate plaque like that could have increased lipids. So that's one thing that you need to rule out separately from the normal macular edema. And then I think in these cases, I probably would go with just steroids. I don't believe in combination therapy in these in any of these cases actually, because I generally prefer to give one injection at a time. And so I'd go with steroids, and also obviously do a fluorescein angiography in this and try to handle the focal leaky microaneurysms. So I mean that would be my plan in these cases.
Probably, in my case, if the patient has good vision, you have sursinates that are temporal to the fovea, and it's non-center involving DME, I would prefer focal laser alone. So you want a more gentle reduction of edema rather than an acute reduction, because the gentle reduction may minimize the tracking of subretinal exudates. But if it's a large plaque at the fovea, the visual prognosis is anyway poor. So I think an injection will do as well. What you're more worried about is the patient with 6.6 or 6.9 and large amount of hard exudates. How do you tackle that? I would probably, if possible, go for focal laser first.
No, I mean, I think most of these which respond with focal laser, Muna, I personally don't feel they migrate to the center. It's usually when you have a lot of hard exudates before the treatment itself that tend to migrate like that. So yeah, the hard exudates are very minimal. I mean, I took the question as there's already significant hard exudates. And if the hard exudates are very minimal, obviously it's going to be focal laser. Yeah.
Also,
Sir,
starting the patient on statins will help. Rosuvastatin or
If
atorvastatin.
there is.
Standard treatment.
sir, in any case, you will go for the combination of anti-VEGF plus dexamethasone injection, or always single injection?
Yeah, Anshuman, yeah. So the reason, Anshuman, I'm not comfortable is there is a what should I say? I mean, there's a volume effect over there, and I would like to see how one injection is functioning first. And I see no reason because macular edema is not an emergency for me, so it's not like you have to give it. Of course, you have to take the patient back to the OT or the minor OT and give the injection. That's obviously there. But at the same time, I want to see what's happening with one injection, and it's not an emergency that I have to treat him back to back at the same sitting. So that's why I've never given a combination, frankly. Yeah,
And sir,
Munna,
if
you use that often, combination treatment, Munna? And Sarvanan, if he's joined back, and the other panelists, Dr. Haig and Dr. George.
and
So,
sir,
Mona,
if you have given one patient, if you have given 7 8 injections, and the edema is coming continuously after a couple of months, whether you will go with this combination, or still you will go with the one injection.
no, Anshuman, see, the whole problem with DME is the recurrence. And now you see, after 5 years, whatever you do, combination, single treatment, you know that 40% are still going to stay with the DME. So I think it is extremely suboptimal. Maybe I think we understand DME very, very poorly. If 40% of them after 5 years are still persisting, I think we really are not doing a good job. So I think it's not about combination or single. I think we're just failing to understand the disease process. And many of the times, I also see that once you've given them so many injections, vitro-retinal interface changes start in, and that also complicates your problem. There is a hyaloid contraction that happens, or a VMA, and then a VMT kind of a situation develops. Sometimes the ERM starts developing. So none of the papers actually discuss this in detail. What was the vitreoretinal? There are separate papers, of course, saying these are the changes and all. But in this 40%, what was the vitreoretinal interface changes? So there's a complexity to the whole thing, and I don't think the answer lies in one injection or a combination injection. And going with, of course, diabetes itself is a complex disease, systemic disease. So I think the answer is not easy at all.
yeah, I don't believe into combination injection, and there is no rationale for them. It has been a trend here in Egypt, but I don't support it, and no clinical trials support it. It's the point is with diabetic macular edema, it's a complication of diabetic retinopathy, which is a very long disease. I mean, for the eye to start show the complications, then there is a lot of derangements in the pathophysiology within the cells of the retina. So I would say it's not our fault, but it's primarily we don't know the pathophysiology. There are four mechanisms that are well settled, but still the molecules that are used till now to treat the disease are not quite efficient to close all the pathways. So this is the point. That's it. So that's why we see a lot of non-responders. Actually, really, it's 40% of the patients are poor responders or non-responders. But with steroids, like we use Ozurdex, you get very fast anatomical response. But the visual acuity depends on the status of the retina. The problem is with Ozurdex or steroids, we use it sometimes as a salvage therapy. You try the anti-VEGF, like 4 injections, 6 injections, 9 injections, then you start to switch on the steroid. At this time, you get very good anatomical results, and it's like in 3 weeks the retina dries. But it's now we return back to the biomarkers of chronicity. I don't consider those biomarkers as a biomarkers of inflammation. All the biomarkers they talk about are, from the practical point of view, are biomarkers of chronicity. So if you have a chronic disease with loss of the external limiting membrane, you have degenerative cysts more than exudative cysts, you don't expect a lot of vision gain. This is the point. So uh, the point, we don't start with steroids. We are all afraid of using a steroid as a primary treatment or molecule to start with. So this is the point. If we come with some form of a agreement when to start primarily with steroids, maybe we can get better results. And now I personally didn't try the faricimab, but according to some colleagues and maybe reports, they get faster results. But still, with the clinical trial of it, they used 4 loading doses for DME, which support the idea that the pathophysiologic mechanisms that lead to the development is too much. So you need to load up the patient. You need to depress the VEGF, long depress the VEGF within the vitreous cavity, maybe to get better results. This is my perspective. Thank you very much. Thank you.
So you got your case?
Yes, I got my case.
Yeah.
Here it is. I have. Do you see it? Here it is. Can you see it? Am I sharing my case?
Yeah, yeah.
Yeah. You see the retinal folds?
Yes.
Here it is. Yeah. This is a typical, and here is the decompensation of the RPE. So it starts to, you see these hyperfluorescence points. Let me see. This is typical of lymphomas, the radial folds, and here's the OCT. You see the folds, the undulation in the RP Brooks membrane complex layer. I get better. Better. So many cases. Anyway, yeah, you will see the undulation, the RPE, and you see the pachychoroid here, and it's infiltrated. I have better pictures with the crop line.
Someone has asked, how long should we give antioxidants in dry AMD patients?
Excuse me?
Use
How long should
antioxidants.
we?
You mean the use antioxidant and lutein zeaxanthin for dry AMD? This is the question?
Yes.
Yeah, actually, we have just a new publication of ophthalmology by Keenan. He reviewed the AREDS study, and he realized that when you take antioxidant or zeaxanthin, we can reduce the progression of the lesion in direction of the fovea. Not the total lesion. The lesion is still growing, but reduce in the study was around 36% of reduction in 1 year. And for now, I think it's good to keep using the antioxidant in the patient with geographic atrophy. And based on this result, I think many other papers will come up after this, and we really don't have something very effective to treat these patients with geographic atrophy. The other 2 medications that was FDA approved, the pegcetacoplan or avastin captad pegol, they has very mild results. It's around the same. If you use for 3 years, you're gonna be around 40% reduction in growing, and it's very expensive and has side effects as induced neovascularization that you have to treat combined with anti-VEGF. And for now, I think we have not too much to offer the patient, and the antioxidants is a good choice.
Can I ask a question to Dr. Mona?
Yes, please go ahead.
Yeah, with type 3 MNV, I guess it's underdiagnosed. So do you have like specific biomarkers, OCT biomarkers for type 3 MNV?
Yeah. The biomarkers for type 3 MNV.
Type 3, yes.
Yeah. I think the
Type 3.
Yeah. So once type 3 has set in and it has reached the sub-RPE space, I think there is no difficulty in identifying it. But the challenge is to find it when it is early and when it is most amenable to treatment. So basically, you can have hyperreflectivity within the inner retinal layers or the middle retina. It starts in the intraretinal spaces. So you have hyperreflectivity there surrounded by macular edema and absence of any other vascular pathology, like a branch vein occlusion or diabetic retinopathy. Cystoid macular edema, intraretinal hemorrhage, and a hyperreflective lesion within the intraretina. That is more likely to be a type 3 lesion, easily identified if the other eye has advanced neovascularization.
Yeah, I mean, with the late stage 4, you get the PEDs and it's pooling with the fluorescein angio. So it's so easy, as you mentioned, in picking it up, but it's the dilemma with picking it up at early stage. And I still rely on angio. It's multimodal imaging. I don't rely on OCT only with the multimodal imaging and fluorescein. If it's a high quality fluorescein, you see the feeding vessels dipping inside and reaching the complex, the hyperreflective complex in the inner nuclear layer. So I'm really more of a multimodal imaging guy, not an OCT only.
Yeah. Yeah. Sometimes OCT angiogram is also a good. If you do a careful OCTA, you may be able to pick out the neovascularization today. Because today's talk was OCT biomarkers. I didn't bring any images of FA and ICG.
No, yeah, no, it's generally it's the multimodal imaging, which connects all the dots because it's one imaging modality. It's just you pick up one or more observations, then it's the visual acuity, it's the clinical exam, it's the fluorescein, it's the OCT, it's the OCT angio, then it's all the cubes comes in together. Then we reach in those equivocal cases the right diagnosis before starting treatment or taking a treatment decisions. Because the late stages type 3, we don't treat them. And the problem with type 3 lesions, it's the early development of geographic atrophy, which is really disappointing. That's what I think and what I've noticed. If you may agree, Dr. Muna.
You can control well the neovascularization type 3, but the problem is the next step, that's angiographic atrophy. And
Exactly, yeah.
more complicated because it's bilateral. All the type 3 in 3 or 5 years is going to be bilateral. And then this is a big problem.
Yes, exactly, yeah. It needs less injections, but it gets very early geographic atrophy. This is the dilemma with type 3 lesions.
They'll follow for 10 years or more. Even if you retreat very few injections and control without a lot of anti-VEGF, they still have geographic atrophy. The problem is, in my view, we have a ischemic choroid, and this ischemic choroid induces this geographic atrophy in this patient that has type 3 lesions. And then it's something that's it's not just because the anti-VEGF can induce atrophy, but because the natural history of the disease is towards atrophy.
And a question to Dr. Muna. How do you identify inflammatory macular neovascularization? The very characteristic OCT biomarkers for inflammatory macular neovascularization for you. You see it right away. This is an inflammatory MNV.
Yeah. Inflammatory is typically type 2. It's pre-RP. And then you have the pitchfork sign, where
What is it?
have
Excuse me?
The
What is
pitchforks.
it?
The pitchfork.
the pitchfork,
Mhm.
where you have those vertical structures going into the retina. You have intraretinal,
Yeah, the transmission. Okay, yeah.
the pitchfork
And
sign. And usually they are type 2 membranes, which are above the RPE. Those are very typical of inflammatory CNV.
Multifocal
yeah,
choroiditis
because
is Pick's syndrome. We can
yeah,
have the kind
but
of type 2
okay,
neovascularization.
yeah.
yeah,
If we're
it's
looking
yeah,
at
it's kind.
PIC, then the lesion is different because it's usually in a myope. You have small punched out lesions. You may have an inner choroidal involvement as well. You see the lesion, a little hyporeflectivity in the underlying choroid. And usually those are associated with myopia. Whereas the other, like with multifocal choroiditis or VKH or something, then you see a pre-RP lesion.
Yeah, I mean, it's always kind of a problem because PIC happens with myopic. So sometimes it's difficult to differentiate between myopic CNV and the ones because of the PIC. And I have seen some good number of patients treated like by 20 injections of Avastin or something because they were just scars from the PIC and not myopic CNV, because as we know from the natural history, myopic CNVs, even if they are left untreated and they are small, they go into fibrosis within a few months. So it's a point to shed line on. Yeah, the PICs and myopic CNVs. Yeah, I'm done.
Right. We have got fellows with us in the meeting. If anybody wants to ask any questions, they can come up right now. Or anyone from the audience, any questions?
I'll ask one question. Ma'am, the case which you shared in your PPT, sub-RP bleed, PCV bleed. The sub-RP bleed, PCV bleed, you shared a case. So in that intravitreal, you gave sub-RP or TPA, or you gave intravitreally only?
That was intravitreal TPA. The patient didn't undergo any surgical procedure. Intravitreal TPA.
Okay. Can we take one question?
Yes, go ahead, Dr. Tanvi.
So some MNVs goes under scarring after giving anti-VEGF and the vision reduces. Is there any biomarker which we can? Hello, am I audible?
Yes, you are
Yes.
audible.
Yeah.
Voice is breaking. I don't know. Maybe it's
So
my
she wants to ask, a few CNVs will the vision will drop after anti-VEGF injection. So is there any way that we can identify which of the CNVs will, the vision will drop after treatment with anti-VEGFs? That's what she wants to ask.
See,
Very close.
fibrosis is always a little unpredictable, but you can sometimes get it in type 2 lesions which are large. Type 1 lesions and PCV rarely gives rise to fibrosis. Sometimes you have a large type 3 membrane and you develop an RP, then you can get a lot of fibrosis. You just have to be a little careful. Type 1 rarely goes into fibrosis. But then it rarely goes away as well. So that's another thing you need to look at. It's usually type 3 that goes into fibrosis.
All right, now I invite Dr. Kaushik Tripathi for closing comments, please.
Thank you, Muna ma'am. The talk was excellent, and I had already seen your previous talks. They are actually inspirational, and we learned many things today. I thank Dr. Atul for inviting Dr. Wael and Dr. Rocha. Dr. Rocha and Dr. Wael, thanks for your time and your comments. I thank Professor Pradeep Venkatesh sir, who has been my teacher and mentor, and we have learned so many things from him. And obviously, clinical diagnosis is one thing which we all must focus on. It is better always important to see with 90D and do indirect ophthalmoscopy and then jump to any investigation, because we are clinician primarily and then we can go to multimodal imaging. I thank Dr. B.R. Sarvanan sir. I thank my teammates at ASJ Academic Cell, Dr. Ganesh, Dr. Mayank, and Dr. Atul. I thank our moderators, Dr. Anshuman and Dr. Tanvi, and I thank all our audiences for their questions. Thank you so much. I think we learned something new today, and again, I would like to thank Mona Madam and our esteemed panelists for their time and comments. Thank you, sir and ma'am.
Thank you, Kaushik. Thank you, Muna. And thank all the panelists for joining in this healthy discussion. Thank you so much.
Good day.
Thank you, everyone. Good night.
Thank you, everyone.
Thank
Bye.
you. Bye.